lines. So appreciate everybody's responses to everything that we are constantly asking for. We have some great presentations today, and yeah, just excited to have everybody here. Thank you for joining us.
Kelly,
Danielle, do you want to introduce yourself real quick?
Yeah, thanks, Kelly and Becky. I'm Danielle Culp, and I'm the Director of Statewide Programs in Criminal Justice. So excited to be on this call. I haven't been able to make a meeting in a while, so it's great to see all your faces. Thanks for having me. Excited for the presenters today too. I think you all will be really excited, pleasantly surprised about what they're sharing. So thanks.
Thanks, Danielle. Do we have Athena with us today?
Yes, I'm on. I'm Athena Puppas. I do your renewal contracts and process your invoices for payment.
Thank you, Athena. We have a lot of people on this call, and I'm trying to rock through, but I can't see everybody. Do we have anybody else from BHA here on the call? All right, cool. So I apologize. You guys deal with us so often all the time that I always forget introductions before we just hop right into it. So now we can hop right into it. So like I said, everybody should have gotten their fiscal year 25 contracts from Athena. You did not get your fiscal year 25 contract for review, please email me or Kelly. We can get that to you. We can just forward it to you. And you can, if you are not the signature authority, that is totally fine. You can get it to whomever the signature authority needs to be. And that should be fine. Just let us know. Sent an email this morning to a couple of folks we didn't hear from on if you wanted to go with option 2, option 1 or option 2, which would be, and I don't know which one is which, but it would be DocuSign or physical signature. So I sent an email to a couple of you this morning because we hadn't heard from you. I have gotten some responses already. So if you haven't responded on if you would like to physically sign the document or go through DocuSign, please let us know that through email so we can make sure we rock and make sure everybody has a fiscal year 25 contract. Any questions, concerns, anything about that? Sweet. Well, I think Kelly has just some information to give you all about the GAIN user agreement that she sent out earlier this week. So go ahead, Kelly.
Yeah, so the only reason that we need to have those user agreements is that is a requirement that Chestnut asks of us. They are the ones who they're going to be housing that data on their web-based software program. So in order for us to do that with them, we have to have each jail sign a data user agreement, just saying that's okay, that this data is housed there because it's PHI, so, but it's all protected and they've got all the safeguards in place. So they just need to get that back from you. And some of you have asked for a signed copy of it back. I emailed them and they said that they do that for everybody regardless. So I don't know when you'll get the signed copy, but the person who's working with us at Chestnut has access to the folder where I am uploading all of these once you get them back to us. So far we've got about 6. So I need for everybody on here to get those done as quickly as possible and to get those sent over to me so that I can give him access to those so we can get the ball rolling with that. Any questions about that? Okay. Also, we have our upcoming GAIN training on, I believe it's the 18th of June. Actually, wait, let's see. Maybe it's coming up. Well, you all will get an invite to the upcoming training that we have on GAIN. We really
the 19th. Kelly, it's the 19th of June.
Okay, thank
Everybody
you.
from 1 p.m. to 3 p.m. Put it on hold. Mainly your clinicians that'll be doing those assessments, they need to attend that. Please put it on hold. Kelly, go. Sorry, I interrupted you.
No, that's okay. Yeah, what Becky said. So any other questions at this point for us before we kind of dive in? right? Okay, hearing none, we're going to go ahead and get started. Our first presenter today is from Indivior. They are going to be speaking to you about a reversal drug called Opvi. I'm going to let Andy, Justin, and Stephanie, you guys go ahead and take it away. I think you're all co-hosts, so you should be good. Just share your screens and we'll go ahead and get started.
Okay, can you guys hear me?
We
Okay,
sure can,
so-
thank you.
Okay, so hi, so my name is Andy Sparks and I am the account director for Indivior for Opvi, our new FDA-approved overdose reversal for the state of Colorado. So thank you guys for allowing us to be on this call. So first, let me I'm gonna figure out how to share my screen for you guys real quick. So give me 1 second here. Hold on. All right, so what we're going to talk about is Opvi. So Opvi is our new overdose reversal drug. Some of you may be aware of it, you've heard of it, maybe not. So I'm going to hopefully give you all kinds of great information. And then let me see here if I can get this going for you. All right. Can you guys see that okay? Okay, so
A copy of this, just curious. Just wondering if I should take notes or if we can.
we are not allowed to share our
Okay.
stuff, but I can send you some information. I can send it to Becky and she can forward it out to you guys if that would work.
Excellent. Yeah, thank you.
I'll just forward it out to this list, no problem.
Okay, great. So wanted to talk to you guys about Opvi first, and then also we'll go through this and then afterwards we can ask questions. And then also wanted to talk to you guys about our new experience program that we just launched. This program would allow for free product for entities like yourselves. It would be 108 units, which is 216 doses for you to try out for free. So I'll go into that after we talk about Opvi. So, as I said, Opvi is the overdose reversal drug. It's different than what you're normally used to. So you're normally used to naloxone, which would be your Narcan, your Cloxato, all kinds of variations of naloxone. So Opvi is a different molecule. So it's nalmefene. It's also a nasal spray, but it's a different molecule. So I'm going to go through some studies here that we did to obtain our FDA approval. So I'll dig right into it and start out. So our first study that we did, we looked at comparing the standard of care 4 milligrams naloxone, so what you are used to of Narcan. And in this study, we took healthy individuals and we gave them a gas mixture high in carbon dioxide, which elevated or artificially elevated their respiratory function. And then we gave them what's called remifentanil, which is a fentanyl analog. And then from there, the participants were given either 1 dose of Opvi, which is 2.7 milligrams of nalmefene, or 1 dose of intranasal naloxone 4 milligrams. And then they were able to collect the data on the recovery phase, and then they did a washout and they did a rinse and repeat to where they switched. If you received the nalmefene the first time, you were given naloxone the second time. So this is the Opvi arm of that study. So the FDA looks at the 5-minute mark of recovery of respiratory. That is kind of their marker point. So when we look at this, you can see where the remifentanil was given. And then at that 0 mark, they gave the intranasal Opvi. And you start to see that line start to increase. And when you look at that 5-minute mark, which is that FDA marker, at 5 minutes, the return to respiratory function was upwards of 98.9%. But if you dig a little deeper and you look at that 2.5-minute mark, the respiratory recovery was at 80%. So that's where you're hoping to start to see those signs of life. You're seeing the eyes open, you're seeing them make breath noises. And the hope is that you don't have to do multiple doses of recovery or overdose reversal at that point because it's working quickly. And then we looked at, there's 2 other studies they did. They're looking at the bioavailability, the max concentration, and the safety profile of Opvi. And from both studies, they determined that the half-life of Opvi is 11.4 hours, which I will dig a little deeper into that in some slides ahead. So if we take a look at this chart, which it's a little busy. So the first study, so what they did is they looked at Opvee intranasal, which is the nasal spray, and then they compared that to the intramuscular nalmefene. And they're looking at the max concentration at the time that it takes to get to that max concentration. So as you can see for Opvee, it was 10.4 nanograms in 15 minutes versus that of 1.5 nanograms in 20 minutes. So the concentration levels were able to get there faster. And one of the reasons why that is that Opvee has an absorption enhancer called Intravale. So that enhancer is making it to where the max concentration is happening in a faster time frame. And then in the safety profile, they're looking at if you did one dose in each nostril, and if you did 2 doses in the same nostril to see that safety profile. And what they determined was regardless of how the doses were given, they all reached the max concentration level around that 15-minute mark. And then as far as adverse events, so the biggest adverse events are going to be similar to what you would see in most overdose reversal drugs, nasal sprays, so nasal discomfort, nausea, headache, very similar to what you would find in other overdose reversal drugs. So just to kind of tie back to what we looked at with those studies, so Opvee again is nalmefene, and it is the first and only opioid rescue medication specifically indicated for opioids and synthetics like fentanyl. And the reason for that is because it's fast. So as we discussed in that 5-minute mark, we were able to return respiratory function to 98.9%. And then again, at that 2.5-minute mark, we saw that it was at 80%. And then it's long lasting. So it has a half-life of 11.4 hours. And why that is important is because previously in our crisis, we were dealing with a heroin Oxycontin crisis, and those do not have a very long half-life. But when we're dealing with fentanyl, fentanyl is a quick high, but it lasts in your body for up to 7.5 hours. So that's where, kind of looking at this chart, you can see that half-hour half-life of heroin, morphine, and then the fentanyl at 7.5 hours. So you want something that's going to mirror that drug and stay on the receptor as long as possible. Because with fentanyl, if they overdose and you give them an overdose rescue, there's a chance, if it's not Opvee and it has less of a half-life, there's a chance that even if they don't do drugs again, they could have another overdose. So, and then this is what it looks like. So it's very similar to what you're used to. It's the nasal spray, just like what you're used to with Narcan. But again, it's fast and it's long lasting. And so for you guys, with what you guys are dealing with in the jail settings, you want to have as little touch points as possible. You want it to be fast. You want to, get them into medical as quickly as possible. And so that's where Opvee is a great solution for you guys. And then it's a 28-month shelf life, and each box comes with 2 doses. And then the way that you can get it through Opvee Direct. It's $75 for a 2-pack. But again, the hope is that it's taking you less doses and that you can, utilize with that fast absorption enhancer that they're coming back quickly. And in that, we want to make sure that they aren't having any type of oxygen, deprived of oxygen for the brain and organs to have even further medical issues. So where we are talking about with the price, that's where I wanted to talk to you guys about the experience program as well. So for right now, there is a way that, like I said, you can get 108 doses or units and 216 doses for free through our experience program. And it's going to the first 200 entities in the country. So it's first come, first serve, but I would absolutely be open to talking to any of you guys about it and seeing if this would be an option for your facilities. So I'm going to stop there and stop sharing my screen here and see if anyone has questions. So I have also on the call Stephanie Garland. So Stephanie is my medical, and I should have introduced her in the beginning, I'm sorry. She's my medical liaison, and she is a PharmD. She comes from a background of poison control, specifically dealing with opioids and fentanyl. So ask us anything you want.
Hi, this is Jen with the medical department. Couple of questions for you. I was looking at kind of the website about this medication. I see that it is not considered over the counter. And it does require a prescription. So, can you kind of talk about that a little bit? Because, like, are you anticipating it to be similar to Narcan, or can you kind of
Sure.
explain that a little bit?
So we are not over the counter, just like Narcan wasn't originally. So the goal is that you guys, whatever process that you go about to get your Narcan would be the same with us. If it's that you purchase direct, if you get it from the Naloxone Project, whatever that process is, that is our goal. Currently right now, we're working, so they're working towards it. And I also have Justin. So Justin Galan's on my team as well, and maybe he could speak to this as well.
Sure. Yeah, no problem. Thank you for the question. So when it comes to mass distribution of overdose reversal medications in the state of Colorado, what was required for a prescription product, and this was, as Andy alluded to, is the same process with Narcan, is there needs to be a statewide standing order that covers all of you, right? Law enforcement, first responders, community-based organizations, groups that are out doing what they can do in and around vulnerable populations to reverse overdoses. So we're very well aware that, this is a very difficult crisis to curb one prescription at a time. So that's a real crucial piece for us in the state of Colorado. So once we get that in place, and we are working on that, as Andy said, it would be the exact same method that you request your Narcan from, or whichever entity or group. And we would we're working towards OPVI being available and therefore paid for through grant funding. So as we do this, the person who is responsible, the physician in your state who's responsible for signing the standing order, he is open to the idea, but he would like to hear from those of you in the state that would like this to be an option for you. So this is part of the reason why we developed the Early Experience Program, which is a no-cost goods program that we can get to folks very similar to what you're doing, law enforcement and corrections. This product plays very well in that environment. For the record, we are never, and we are not implying that we want to replace Narcan on any level. We believe in Narcan. We believe that Narcan is a very important piece of saving lives during this crisis, and we have to have Narcan saturation. Where OPVI fits really well is think about your jurisdictions, think about parts of your state and your cities where you have hotspots of fentanyl overdoses, whether they're people who are active users or they're accidental and there's poisonings occurring. That's where we can deploy OPVI and start to tamp down overdoses and start saving more lives. So anyway, that's that. I hope I answered your question. Thank you.
Do we have any other questions?
Hi, this is Dr. Jones. I'm just curious what the price difference in the IM and the intranasal is.
Did you all hear that question?
Yes.
Sorry, I'll let Justin
Yes.
answer that one.
So when you're referring to the intermuscular nalmefene versus the nasal nalmefene?
Yes, exactly.
So right now, my understanding is there's one manufacturer that is putting out the intermuscular nalmefene. It's very, very low distribution, and it's only in the hospital setting. The nasal nalmefene, and so I don't know the cost of that. I apologize. The cost for ours, the nasal nalmefene, which is intended for community use and to be pushed out in mass distribution, a unit is priced at $75, which is the exact same price that Narcan came to market with, and so that's $37.50 per dose. There's 2 doses per unit, and so that's how it comes out. So if a group were to purchase through grant funding, that would be their price. We call it the public interest price, and once we get to the point where OPVI is available at the state level, then it would just be requested by you or your entity, and you would receive that through those grants.
Thank you.
You're welcome.
Looks like we had another question in the chat. Is it effective against xylazine overdoses?
I can take that one if you
I'll
all.
take Stephanie.
So xylazine is not an opioid. So any of your opioid reversal agents, including Opvee, would not be effective against it. But for the most part, at least in the western half of the United States right now, when we see xylazine, it's usually mixed with fentanyl or some other type of opioid. With it, it's rarely just pure xylazine that's seen. And so in that case, if it's a mixed kind of bag there, Opvee and the other opioid reversal agents could work on the opioid aspect, but it's not going to have specific activity against xylazine.
Thank you for that. Any other questions? If you all can take a look in the chat, Andy and Justin have put their contact information in there, as well as Stephanie did as well. So I think that it would be great to connect with these folks and talk about this as a possibility in your facilities.
And thank you guys so much. We appreciate you guys letting us be on this call. And, like Justin said, as far as the state standing order, as of right now, it's not agnostic, but in Arizona, Utah, New Mexico, it's all been changed to agnostic because we're not going to be the last product. The drug supply is going to continue to shift. So any support that you guys can reach out to Dr. Colon to just let him know that you would like for it to be agnostic for kind of forward thinking. It would help the state and get that agnostic standing order. And then again, for the experience program, please reach out to me and I can go through it with you if your facility you think would want to utilize this and try it out. We've got experience programs happening all over the country, from sheriff's office to jails to community-based organizations that are all looking to do the program and hopefully provide that feedback of what they're seeing so that we can go back to the state and utilize that information to get it to be an available option using SOAR grant funding. So we appreciate it. And my contact's in there. Please email me and I will send some information to Becky that she can send out to you guys. And just let us know if you have any questions. And we appreciate your time.
Thank you.
Thank you.
Thanks, everybody. Appreciate you.
Yes, thank you. Thanks so much. We're going to jump right into our next presenter, also from Indivior, David Gentry, and I'm going to try to say your name right. Imanga?
Very close. It was Amanga. Thank you, Kelly. No worries.
They're on the call with us as well. They're going to be giving us some information on Sublocade. So I'm going to go ahead and pass it over to both of you. Thank you.
Yeah. Hey, good morning, everyone. We're excited to meet with you all this morning. My name is David Gentry. I am the CJS Market Access Director for the state of Colorado. We have the long-acting buprenorphine product. It's an injectable. It's Sublocade. I am joined today by my two colleagues, Amanga Akinde, who is the Medical Outcomes and Values Liaison, as well as retired Under Sheriff Jeff Clark. We're excited to be able to share a little bit about the medication Sublocade. We've got a few slides that we'll be sharing. Amanga has a real-world study that she'll be presenting, and we'd like to make sure that your questions are answered. We know there's a lot of folks on this call, and so if there's something that you feel like you'd like to have answered, please submit that or ask us, and if necessary, please interrupt Amanga. We want to make sure that this is a two-way dialogue and that you're getting your questions answered. With that said, Amanga, would you mind giving a quick introduction, and then we'll have Jeff share a little bit too?
Of course, happy to do so. Good morning, everybody. As Dave mentioned, my name is Amanga Akinde. I'm a licensed pharmacist and I work as Dave's medical counterpart. So being able to speak about our medications on label as well as off label. I'm really excited to meet with you guys here on the call. I know there's quite a bit of folks here. This is really just supposed to be educational for you all, so I'll try to keep it as engaging as possible. But please feel free to interrupt and ask questions. We'll really try to look at some of the science science behind Sublocade, and then also look at this real world application, understanding how this can affect costs in terms of staffing. So very excited to present this information and hoping that this can be informative for all of you. So thanks for having us on the call today.
Thank you. Jeff, are you on as well?
I am. Thank you, Dave. Hello, everyone, and very, very great to be here. My name is Jeff Clark, and like Dave said, I am a retired undersheriff from Washington County Sheriff's Office in Reno, Nevada, where I spent 28 years, and a lot of that time was assisting in building programs within our detention center. One being medication-assisted treatment. We started about 8 years ago with a medication-assisted treatment program using buprenorphine products, Suboxone, and really other MAT products. I always tell people our goal should be to meet people where they're at, and so that's really kind of my specialty is just talking with facilities about medication-assisted treatment programs. After I retired, I did go to work for the Bureau BJA, the Bureau of Justice, and I was consulting in jails across the country, just talking to them about the importance of medication-assisted treatment and meeting people where they are. Now I'm so fortunate to work for Indivior, and really the product we're going to talk about is Sublocade, and there's a lot of reasons that Sublocade makes sense for correctional facilities because it does cut down on diversion, which is really inmates trying to trade products and give products to other inmates. And then really staffing issues. By a long-acting injectable, they don't have to provide treatment every single day, and which interrupts their med passes and things like that. So that's my specialty. I don't want to take up too much time because Amanda is amazing and she'll give you a lot of the medical details for Sublocade. But I am definitely here. I'll be on the call if I can answer any questions as far as the transition in jails or anything related to medication-assisted treatment. I would love to answer them. Thank you.
Great. Thank you very much, Jeff and Amanda. I just wanted to say thank you for the work that you all are doing. I know that many of you are personally connected to this space and the work that you're doing on behalf of those that are incarcerated, that are in recovery. We just want to say thank you, and we're glad to be able to have this opportunity to partner with you this morning, and excited to share some information with the real world study that Amanda will be presenting. So thanks so much, and we'll get started with Amanda.
Awesome. So I'll go ahead and share my screen. And just let me know if you guys can see that. We typically use Teams, so I'm not as well versed with Zoom. So apologies if anything goes awry today. Okay, awesome. So I got a thumbs up from Becky, so I think we're good to go. So just to start off, I did want to start with information about Sublocade. So I know that months back, I think a few of you got a more deeper dive presentation on Sublocade the medication from my colleague Jessica J. But I did want to just start off with just some information about it, just for those on the call that might not be as familiar, and then we'll hop into the real world evidence study. So starting off with some general information about Sublocade. So just so we're all aware, it is that long-acting buprenorphine injection that's injected into the subcutaneous space, that abdominal subcutaneous injection. That image on the side, there's kind of a good depiction of what it may look like in practice. So it does contain Indivior's proprietary buprenorphine gel deposit delivery system. That's that Atrigel technology. So when the medication comes in contact with a patient's body fluid, it forms this kind of semi-solid mass, and it's able to deliver these bits of buprenorphine throughout that patient's system throughout the month until the time of their next injection. As time goes on, that depot does get smaller and smaller as that kind of degrades over time, and more of that buprenorphine is pushed through that patient's system. We would expect that nodule gets smaller in size 2 to 3 months down the line, so it's no longer visible to the eye or palpable to the touch. We can't see it or touch it. And that NMP component, which is part of that Atrigel, is able to diffuse quickly over 3 to 4 days. So just important to let the inmate know, the patient know, that when they're receiving this injection, they do have this lump on the top layer of the skin, and that's really just the medication working on their behalf. Any questions so far about the delivery system of Sublocade? Awesome. Moving into some of the science now. So just understanding the importance behind why with Sublocade. So I know this is quite a busy slide. I'll try to orient you as best I can just to get the most information from this. So starting off with this box here on the right-hand side, or your left, my right, looking at the association between mu opioid receptor and opioid use disorder symptoms. So this is all based on buprenorphine, right? So Sublocade is solely a buprenorphine injection that's essentially diffused through that patient's system over the duration of a month. So it's kind of month time. Now, all of this is, this is great, but kind of why, the why behind it. And understanding that buprenorphine is really dependent, what we see about it in practice is really dependent on the concentration that we're able to reach in the system. So buprenorphine kind of has 3 hallmarks to it. The first is that it has a very high affinity for the mu opioid receptor. So what does that mean? It really seeks out the receptor once it enters into the system. So it's kind of always looking for that mu opioid receptor once it enters into the body. The second is that once it latches onto the receptor, it's very difficult for it to come off. So it really seeks out the receptor. It's very difficult for it to come off once it actually connects with the receptor and attaches. And then the last hallmark with buprenorphine is that it has that ceiling effect. So at a certain point, no matter how much you put into the system, we're still not going to see those clinical manifestations like you would with an agonist like methadone or heroin or OxyContin. If you put more in the system, that increases the chances of something like a respiratory depression because more and more of that is being overloaded to the system and not being wasted. So kind of understanding those 3 hallmarks of buprenorphine, what would happen since we have a finite amount or a set amount of mu opioid receptors if you overloaded majority of those receptors with buprenorphine? Because it has that high affinity, even though it's a partial agonist, and it has that slow dissociation, so it's slow to come off, it creates a lot of competition at that receptor site for another medication, in this case, let's say another thing like methadone or heroin, to come in and make its effects known. So this is all dependent on concentration. So that leads us back to this box here, where we see when buprenorphine reaches concentrations of greater than 2 nanograms per milliliter, this interesting thing happens. It has a much higher mu opioid receptor occupancy. So more of those mu opioid receptors are occupied in the brain. So if we think about this from a real world perspective, let's say we had a parking lot with 100 spaces, and buprenorphine is going to be a bunch of blue cars. So you are the parking lot attendant, you let in a bunch of blue cars in, let's say you let in 75 blue cars in. Majority of those parking spots are going to be occupied by those blue cars. Now, if you let in a set of red cars in, it's going to be very difficult, even if you let in the same amount, to get into those parking spaces and kind of be able to park and get into the store. So that's really what we're seeing here is when you've got this set amount of receptors in the brain, if majority of them are occupied by buprenorphine, it makes it really difficult for another medication to latch onto the receptor and make its effects known. And I should say another medication, another mu agonist. Like I said, the options would be something like methadone or oxycodone or heroin, fentanyl, things like that. So once you reach those concentrations, majority of those receptors are occupied. A lot of these studies led to kind of looking at how if you reach these concentrations, you have majority of the receptors occupied. This also makes it very difficult for another agonist to come in and make its effects known. So this really led to led to a formulation that was really targeted to maintain these concentrations throughout the duration of the month. So looking at making sure we maintain a concentration of greater than 2 nanograms per milliliter in the serum or in the body, which also correlates to a much higher occupancy of mu opioid receptor sites in the brain, so greater than 70%. And if you think about somebody with opioid use disorder, why this matters, if we're able to hide the brain with buprenorphine, we can really start to reprogram the mind because we know that addiction plays such a large role with the dopamine pathway. So we can focus on other things like psychosocial support or behavioral health management of the brain as we occupy it with using that buprenorphine for somebody with opioid use disorder. And also helps to reduce the risk of if they were to use something on top or to to happen. I mean, we understand that these are folks that are quite at risk, and we know that this is a chronic brain disease. If they do happen to use something else, it makes it really difficult for that medication to kind of work or make its effects known because the buprenorphine is already on board. So I know it's quite a bit of information, but really just understanding the science and the why behind Sublocade, this is really how it came to be. So this is looking at mu-opioid receptor occupancy over time. Unfortunately, this was with oral dosing of buprenorphine. So we know that oral dosing is very helpful and impactful, but just as Jeff had mentioned, the big thing that we have to worry about is things like diversion as well as non-compliance. There's a lot of issues that we think about where we're not necessarily always sure that people are using this properly. Are they using it and selling it, or are they actually taking the medication? Because this is a long-acting injectable that's delivered to the patient, we know that it is directly for that patient. They're receiving that injection and they're receiving that buprenorphine steadily at those concentrations, which we just saw in the previous slide, to be so helpful for them over the duration of the month. So it is also very much so time dependent when we think about oral. So with oral administration, we see that decrease in mu-opioid receptor occupancy, and it's also an increase in the availability of how those receptors, in terms of if we're not making sure that that patient is compliant or always taking their dose, the chances of that receptor being open for another drug to kind of come in and make its effects known are higher. So I'll go back to the outline, but I just wanted to stop and ask if there are any questions a little bit about the science before we hop into the real world evidence study.
I am not seeing any questions in the chat, so I think you are good to continue.
Perfect. I'm going to move this. So I'll move into our real world evidence study. Let me just refresh my page here. So this is looking at extended release buprenorphine, specifically Sublocade, and staffing time and costs in the U.S. criminal justice system. It should be noted that this was a poster presented at the National on Correctional Healthcare, or NCCHC, back in July of 2023, so just last year. Also to note some disclosures about this poster. It was done by 3 of the poster authors are employees of Indivior. This study was also sponsored by Indivior, and the writing and editorial support funded by Indivior was also provided by Extenda. So just noting some of the disclosures with this presentation. It is proprietary, so I cannot send you this particular slide deck, but I'm happy to share the poster as available on our medical affairs website. So to start off, because we're talking about Sublocade, there is an indication in ports and safety information, which I think is helpful here because we're just level setting and talking about Sublocade. So we know it's that buprenorphine extended release injection for the treatment of moderate to severe opioid use disorder in patients who have initiated treatment with an oral buprenorphine containing product and dose adjusted for a minimum of 7 days. Now, we know for patients that are naive to buprenorphine, we always want to follow this pattern of making sure to start off with an oral bup product first, dose adjusting for that 7 days, and then leading into Sublocade. If you think now about your patients that are already established on oral buprenorphine therapy, it's very easy to transition over to Sublocade. There's no need to do the lead-in of the dose adjustment for the 7 days. Of course, making sure that there are positive patient outcomes, we want to make sure that Sublocade is used as a complete treatment plan that includes things like counseling as well as psychosocial support. The highlighted safety information here is about our REMS program. So we talked about this a little bit earlier, but Sublocade does form that semi-solid mass when it's introduced into the system. I know this is a closed network, so this would never happen. I think more so looking at this outside of the walls, this really just helps to protect the patient. So making sure that they never pick this up from like an outpatient pharmacy, take it home and deliver it to themselves. Sublocade can only be administered by a healthcare professional to a patient. So it's essentially how we are able to mitigate the risk of any serious harm or death with intravenous administration of Sublocade. And then the last thing on the screen talks about contraindications. So Sublocade should not be administered to any patients that have a hypersensitivity to buprenorphine. Very easy to catch that when we're starting off with an oral buprenorphine product first before we do the Sublocade injection, or any hypersensitivity to the Actigel delivery technology for Sublocade. So moving into the poster presentation, so we see the lists of individuals that participated in this. This was from our real world evidence department. So they were the ones that presented this information at the NCCHC conference last year in Washington, DC. So kind of objectives, backgrounds and objectives. So the primary objectives of this study was really to evaluate the potential for different MOUD programs, MOUD standing for Medications for Opioid Use Disorder programs, that and looking at the staffing costs associated with the different MOUD programs within the United States criminal justice systems. So if you had a staffing program that just was based off of oral medications, maybe just using methadone or just using oral buprenorphine, or some that did a mix of oral buprenorphine and long-acting injectable naltrexone or buprenorphine. So really understanding the differences between those different programs, depending on the medications that they use and that burden that we see on staff. So in the United States, there are up to 20% of state and federal prisoners report lifetime opioid use. The prevalence, which has increased by over 25% between 2004 and 2016, which we can probably surmise is maybe even higher now post-COVID. MUOD are widely unavailable within the criminal justice system, despite the condition's high prevalence, as we see that previous statistic there. Unfortunately, as we all know, that there are those limited resources, such as staffing, that may create those barriers to care. If there's nobody there to kind of watch those inmates, make sure to deliver that medication, it can sometimes be very difficult to implement a program with medications for opioid use disorder. And then the last bullet here, talking about buprenorphine as a long-acting injectable monthly subcutaneous injection, XR buprenorphine, may help to reduce staffing time and resources versus some of the comparators. And we'll see that here in this presentation. So the methods that were used for this presentation is the cost impact model. So it was developed back in 2022, which was to look at the United States CJS staff, including clinicians as well as security officers, the time needed to prepare and administer MOUD. And this could be either oral in the form of methadone liquid or buprenorphine tablet, or monthly injections. As I mentioned, we could either look at Sublocade or long-acting naltrexone in the form of Vivitrol. So they used also prescribing information, expert opinion, and targeted literature review to kind of understand security officers' time and responsibilities, and were able to compile that using those three subsets. And then the clinician time and preparation administration for either XR buprenorphine or XR naltrexone was captured using a micro-costing approach. So looking at the steps that were taken to minimize drug diversion, so if that's monitoring patients or kind of what it would take for a place to another with behind the walls to make sure that they get their medication, and looking at the total staffing costs was calculated using a national mean wages and of licensed practice nurses and security officers. So this is kind of an average, understanding that there may be some places that go slightly above or slightly below. I think I skipped ahead here. So results and limitations. So starting off with results, total staffing hours to treat 100 incarcerated persons. For the XR buprenorphine and the XR naltrexone, additional time was required to prepare worksheets, collect the drug, check and release, just because it is a long-acting injectable. Sublocade is a refrigerated medication, so you do have to take it out of the fridge and kind of let it reach room temperature before administering it to the patient, unlike things like methadone and liquid buprenorphine tablets. But overall, the time needed for oral administration of medications was significantly higher than with the long-acting injectables. And you can see that in the chart here. So when we look at the biggest block we see is dispensing and security. We see that took over 275 hours per month. And with the buprenorphine tablet, that was a little bit larger with 300. So we see that there's a huge time burden when we think about dispensing the medication and the security that's required from officers or clinicians in order to administer these medications. That time is significantly reduced when we think about long-acting buprenorphine or long-acting naltrexone administration. 34 and 38 hours. So comparing the two. So even though it would take a little bit more time to prepare the medication and do those worksheets in order to administer the medication to the patient, that burden of time is greatly reduced when we compare all the other subsets within administering a medication to a patient. So even looking at drug collection, administration, we see that that time burden is extremely much higher with the oral administration medications. We see that's 38 hours per month and 50 hours for buprenorphine. It's very difficult to see what that sliver of time is even for the long-acting buprenorphine and long-acting naltrexone. This box over here on the side kind of helps to break down this a little bit further. So looking at total monthly hours, when we think about methadone liquid, the hours for clinicians, 138 versus security, 311. We compare that to buprenorphine tablets, the long-acting buprenorphine injection, and the long-acting naltrexone injection. So you see a very heavy time burden is necessary for those oral medications. And then looking at resource use assumptions required for dosing, preparation, and administration of medications for opioid use disorder. Administration of methadone liquid is assumed to take 45 seconds per patient using an automated dispensing system. So if you had somebody, an automatic system going. For buprenorphine tablets, it's assumed to take about 10 out of 15 minutes, which we kind of see on that previous slide, why that time burden can be significantly higher, especially with oral buprenorphine, which is spent on crushing the buprenorphine tablet and placing it on the patient's tongue for a group of 10 incarcerated persons at a time. So this is looking at a group of 10. I mean, understanding that there are facilities that might hold more, and depending on your protocols of how you guys do this, that could be quite a significant time burden that you're taking on, and what that looks like for cost. So if you're looking at a clinician, that's $34.02 per hour versus security officer per hour and minutes, looking at how that time burden and what that translates to in dollars for methadone, buprenorphine, and again, significantly lower in terms of observation and completion for your long-acting injectables, but maybe slightly higher, but higher in comparison to the methadone and buprenorphine in terms of preparation, check and release. But when you look at all the numbers combined together, still the oral administrations of the medication take up significantly more time and have more of a cost burden for the facility. So total staffing costs per month to treat 100 incarcerated persons. Long-acting buprenorphine is estimated to save about $15,071 in total staffing costs per month. So this is really looking at the dollar per time breakdown compared to buprenorphine tablets. $13,769 that XR buprenorphine saves compared to methadone liquid, and $222 compared to extended release naltrexone. So in the end, XR buprenorphine is able to save time as well as money, so resources that could be put into a lot of different other things, as I'm sure you guys can attest to, for all the different types of MOUD, looking at oral buprenorphine, oral methadone liquid, as well as long-acting naltrexone injections. And that's seen for both security as well as clinicians. So again, freeing up time and resources for both of these much needed individuals and resources within the criminal justice system to be kind of deferred to other areas. So results in terms of time of preparation and administration steps for release buprenorphine and extended release naltrexone. So understanding that the previous slide talked about $220 would be saved, more dollars would be saved using long-acting buprenorphine versus long-acting naltrexone, understanding that breakdown. So 15 minutes is kind of the requirement needed for the preparation of long-acting buprenorphine versus 45 minutes that we see with long-acting naltrexone. So we understand that with buprenorphine, or specifically with Sublocade, it is a pre-filled syringe with either the 300 milligram or the 100 milligram dose. It does come with that needle, the 19 gauge 5/8 inch needle that does come all together. So just attaching that on and allowing it, the 15-minute goes back to what I had mentioned earlier, which is allowing it to reach room temperature before it is administered to the patient. We know that there are several other steps with the long-acting naltrexone because it is a vial and it is something that's administered to the patient intramuscularly. So being able to tap the vial, insert the needle and withdraw the diluent, mix the powder and the diluent, and then withdraw that suspension, and then administer to the patient. So that's kind of where that extra dollars are saved for the long-acting buprenorphine, because it does come pre-filled versus long-acting naltrexone, which takes a little bit more time to administer to the patient, the 15 minutes versus the 45. And then in terms of limitations, so of course, talking about the limiting effects of this study, I should say, data for clinician time for preparing worksheets, data collection, and check and release for XR buprenorphine and XR naltrexone was assumed to be the same as preparation for oncology treatments due to lack of existing data for MOUD within the criminal justice space. So as we saw on that first slide, we know that many people are coming into the criminal justice space who may be dealing with opioid use disorder, whether or not they've been diagnosed, but a lot of those individuals are unfortunately not receiving treatment, which makes it, again, very difficult to even research this space because the existing data it can be quite limited. So kind of making an assumption, we compare how long would it actually take to prepare this medication in terms of data from the patient or making it work through insurance and all that information and preparing those worksheets. And then in terms of administering MOUD or medications for disorder, they're based on assumptions, and micro-costing exercises and actual administration times may be different. So of course we talk about technique. It may take one clinician a lot less time to deliver something than more, but those are just looking at averages. On average, we know that it takes about 15 minutes to let that medication reach room temperature for long-acting buprenorphine in the form of Sublocade, but the time to actually administer it to the patient, I mean, can vary, but really between about a minute or two, not anything longer than that. And then data on escorting patients were only available for treatment with buprenorphine tablets. Assumptions were made for methadone liquid, XR buprenorphine, and XR naltrexone. And again, going back to that first bullet point, the data or the lack of existing data for medications for opioid use disorder within the criminal justice space leads us to have to kind of assume some things because we just unfortunately do not know. I hope that this was informative and kind of just helpful to kind of see that full picture, understanding the science behind Sublocade as a medication, some of those general information about it, why that's important for somebody with opioid use disorder, and how that can affect your facilities when we think about the time and cost burden that you have to take on with other medications, as well as with using this medication, and how that frees up more time as well as more funds, depending on how you're utilizing different forms of medications for opioid use disorder. So with that, I'll happily take any questions that come to mind, and I will stop sharing. I can get to Zoom.
Did anybody have any questions that you would like? I was looking in the chat. I don't see any, but it doesn't mean there might not still be some.
I have a question.
It looks like we have a question about the cost. Is that something we could discuss?
Definitely. Dave, I'll hand it over to you.
Yeah, absolutely. Yeah. So Sublocade has a wholesale acquisition cost that's a little over $2,000. That is not applicable to the CJS systems. There are discounts available for that, and it's going to be probably in the $1,600 range cost wise. Those are programs that can be signed up at the local jails to be able to receive those discounts. There are also agreements with Diamond Specialty Pharmacy that has some of those in place as well with those discounts. And there is also a program that's available for pending insurance. We know that sometimes folks that are getting out of a CJS system have insurance that might be pending, whether it's Medicaid or commercial or even Medicare. And we don't want those folks not to have medication. And so there are 2 free injections that are available to the receiving provider. And that is just, just in case that the insurance is pending. We know sometimes Medicaid can turn on quickly in Colorado, but not always. And so we want to make sure that those gaps are met and that there's medication that is free for those folks for up to 2 injections.
Okay, another question. When you say healthcare professional, can a nurse administer it, or would it have to be a doctor?
That is a great question. Yeah, so someone who can administer Sublocade just needs to be we've got everyone from doctors to pharmacists to nurses, and even medical assistants are capable of being able to administer it in a jail or in a clinic as well.
What about an EMT?
I think it's probably eligible. They would be eligible as well. It's really just it's a wide eligibility format. It's just somebody who is a healthcare professional. If an EMT is administering these type of medications, I think they'd be qualified as well.
And we can come and offer RIMS training to all the staff and ensure that anybody that is administering has the proper RIMS training.
As far as on Medicaid, it is covered. There is no prior authorization, so it is covered for Medicaid patients. Just as folks are getting out of a CJS system, it would be covered.
Great. Do we have
any questions for Jeff? I know Jeff has got kind of our subject matter expert, who's a former retired undersheriff, and certainly has a lot of experience in implementing these programs in his facility. I don't know if there's any questions for Jeff.
Yeah, thanks, Dave. And I was going to say, Kelly, first and foremost, like Dave has said, we appreciate the opportunity to talk with all your staff at these type meetings. Oftentimes when we're going around and working with jails on medication-assisted treatment, we get questions from both medical and from the correctional staff is why now? Like, why is there this big push for medication-assisted treatment in jails? And I've told jails across the country, first and foremost, this is a national push to get control over addiction. We know, right, that those that are incarcerated play a significant role in the communities, and people are going back to the communities from your local jails. And with the number of people that are dying with drug overdose, depending on what you read, last year, anywhere from 109 to 111,000 people died. And what this product does is it really saves people from overdose. If we can get people, this population, medicated and educated prior to release, we all know that, right, with OUD, upon release is when the cravings are at the highest. And so when they get out of jail and they do go back to their communities, back to their friends, back to the same areas, that's why our overdoses are so high, is because of their tolerance. And with fentanyl on the market and really chemically created compounds, they don't have the ability and the tolerance when they get out of jail. If we're able to get a buprenorphine or product, or certainly Sublocade, on board, it prevents them from overdosing. They can't overdose if they have that product and those mu receptors are already filled. It prevents overdose as well. And really, so that's the goal. Although this is a national push, and that's why you're seeing, Washington, D.C. release a lot of money to help with addiction and getting control over this. Obviously, that supports the settlement funds as well. And so oftentimes jail administrators, that's the first question is, well, how do I pay for this? And, there are a lot of avenues with Health and Human Services and the states, as they receive settlement funding to use towards medication-assisted treatment in jails. Because we know for a fact that if we start with our incarcerated population, that it's going to grow outside within the communities. And we're even seeing hospitals now that are starting to treat OUD by giving Suboxone or a buprenorphine product when people come in as overdose patients. So that's what I have, and be happy to answer questions on the custody side or incarcerated side from any of you.
So it looks like there was a question from Rita. Was it? I didn't see it. It popped up. Are there lower cost competitive products in the market similar to yours? I don't know of anyone that's obviously there is a new product that has entered the market. I think they are similar in terms of their pricing structure, but I don't know. I haven't seen that. But that's that's probably a question for them.
Okay, thank you.
Yeah, no problem. Yeah, I think, Jeff, you make some good points here. Obviously, when somebody's leaving a criminal justice system, they are vulnerable to go back into their home communities and potentially start using again. I mean, the nice thing about having a long-acting injectable on board is that you've got 30 days of medication. It has the potential to have a harm reduction in terms of people that potentially may try and use on top. There was some clinical studies that showed in a phase 2 trial that Sublocade blocked the high or the subjective liking effect. And so we know that there's utility in having a long-acting injectable on board. When you have someone who's on a shorter term medication that's a daily medication that's oral, we know that they can obviously transition off very quickly on those products and be able to use within a few days. And that's really the beauty of Sublocade, is that somebody leaving a CJS system has that 30 days of medication on board. And so if there is a chance to be to use again when they're back in their home communities, at least you've got medication there to help reduce some of the harm there. Amanda, did I capture that correctly? I want to make sure that we're given the fair balance here.
I would say definitely. So we just, it's an excellent tool for the treatment of moderate to severe opioid use disorder. It can also be utilized for harm reduction as well. I think you bring up an excellent point, Jeff, and as well as you, Dave, of making sure that it's on board so we can see the protective nature of the medication because of the way that buprenorphine works in the system. So I'd say that's perfect.
Hey, Amanda, can you talk a little bit about that too while we're on it? Because I think it's important for people to understand with fentanyl is that fentanyl is very strong. It will stay in fat cells. And so if somebody is not protected, even if they were on a Suboxone based product, that as that Suboxone wears off, that fentanyl can take back over those receptors and ultimately cause them to start withdrawing or overdose.
Yep. So I think Jeff brings up a really good scenario when we think about the differences between oral buprenorphine administration versus long-acting injectable administration. We know that oral can still reach those concentrations of 2 nanograms per milliliter, which we saw earlier was so helpful and protective for somebody with opioid use disorder, but they're very dependent on compliance. So making sure that that patient is taking that medication every day as instructed. When we think about daily dosing or twice daily or 3 times a day, it's important that they have that medication every single day. Because if they don't, we bring up that really good point that even though buprenorphine does really seek out that receptor, and once it latches on, it's difficult for it to come off. All of those things are concentration dependent, meaning you have to maintain those levels at a certain point to see those kind of hallmarks that we talked about. So if you're not taking it every day, we see that those buprenorphine concentrations will decrease with time, especially because it's an oral medication. So it's kind of quickly going into the system or going into the system much faster and also leaving the system a little bit faster. And because fentanyl is a very potent opioid and it is very lipophilic, so as Jeff mentioned, it sits in those fat cells, it can kind of try to latch on the receptor and it might not work the first time and it'll kind of sit in those fat cells and then come out hours later. And if there is nothing on board or if that patient isn't compliant in taking their medications daily, it has a chance then to latch onto the receptor and make its effects known. So that's a lot different than when we think about Sublocade because it's kind of steadily administering buprenorphine throughout the duration of the month and still hitting those concentrations, even though it's a slow administration of buprenorphine, which makes it really difficult that even if fentanyl were to leave the fat cells, it really has nowhere to go because buprenorphine is going to just always be there on that receptor and make it very difficult for fentanyl to kind of latch on and make its effects known. So very good point to bring up to kind of look at the difference between oral buprenorphine, which is very time dependent and compliance dependent, versus Sublocade, which is really working on that patient's behalf, regardless if they're taking something every single day.
Kelly, the other thing that I'd like to add, and I know your guys' time is valuable and you're trying to stick with your agenda, is the other thing that we talk about or that we question that we get quite often is, well, how long does somebody have to be on medication assisted treatment, or how long do they need to be on Sublocade? And really that varies. It varies between patients. It varies between how much they're using. But when we talk about steady state, and steady state is really ensuring that they have that 2 nanograms or above, and that they're not feeling any effects of withdrawal or cravings, which are the two biggest things with the addiction, right? And so we're trying to get steady state, which is 3 to 5 months, so 3 to 5 injections. And then we know through research, right, that they will stay above that 2 nanograms, and there won't be peaks and valleys. They won't be feeling like the drug's wearing off. That they'll hit steady state, and then once they hit steady state, then they're gonna feel that, not feel any difference from day to day or week to week. And so minimally we like to say 3 to 5 months, to get somebody to steady state. And then it really depends on, their social skills. Where are they? What are they doing? Are they able to work? Are they able to take care of their family? How long do they have to be on it is really up to an individual patient. We see people on it for years, and we see people that are able to be tapered off, depending on their social, environmental, aspects of their lives. So it is really patient specific. But I wanted to say again, Kelly, thank you, and I'll turn it back over to Dave.
Yeah, I saw there was one question around, is it covered on Medicaid? The answer is yes. Colorado Medicaid does cover it with no prior authorization. So that's an added benefit for somebody who is transitioning back into the community. So good question there. Lastly, I know we're probably up against the clock here. I will let you know that there is a program that we have that supports transition of care. I know that's often a question, that if somebody is currently being treated and while they're incarcerated, who's going to receive that patient when they're leaving. And so we have a patient access specialist. Her name is Wanda Drummond. That is her role, is to be able to help connect folks leaving a CJS system with a community provider, so that continuity of care continues to be there. If somebody's leaving, going back to a small community, we can be able to see if there is a provider in that area that would be willing to receive that patient coming back. And so that's another service that we can be able to support with. I see a question, do they telehealth? You're talking about the providers. You're talking about doing telehealth from a. So I know that telehealth is being implemented. There is a workaround in terms of who will administer it. There are in the state of Colorado safe ways that are available that will be able to see that patient on behalf of the telehealth provider. So you would send them to an Albertsons or a Safeway pharmacy, and then they would do the injection on behalf of that telehealth provider. Does that answer their question?
Cassandra, did that answer your question? Okay.
Perfect.
Thank you.
Yeah, no, we're so grateful again for the work that you all are doing. I am available. I know that we're making good progress in Colorado, but I still feel like there's still some work to be done. I can help assist in the jails in terms of logistics, how to acquire the product, how to be able to get the discount pricing, how to be able to answer any of the medical questions, and then also be able to make those connections within the community providers within the transition of care. So I've left my information in the chat there. Happy to follow up with anyone who's got additional questions. And again, we're grateful for your time this morning.
Fantastic. Thank you so much, all of you. This has been just really great information. And this is certainly something that's a hot topic, as we all know, and is going to continue to be. So just appreciate your thoroughness and explaining all of this. And it's nice to know that there are people out there doing this work and who really care about this and care about this population. So thank you both very much. Or thank you, all of you, all three of you.
Thank you.
We are probably going to go ahead and jump into our next presentation, which also has to do with medication-assisted treatment. I would like to introduce Lori Stolen and Bren Manaw. They are from Health Management Associates. And I will go ahead and turn it over to you, ladies, and let you get started.
Thank you, Kelly. We're really happy to be here. Lori, you want to go ahead and pull our deck up? So we're really going to shift gears with you guys. Of course, that was a really important and needed deep dive into some of the technical aspects of making MAT happen in your jail and making sure people get evidence-based and effective treatment. So we're going to really look at sort of the larger context of kind of the people part of making MAT happen in your jail and making sure it's working well and continues to work well. We want to just briefly introduce ourselves, the reason we're on today. Laurie and I are both affiliated with the Denver office of Health Management Associates. If you want to go ahead and go to the next slide, Laurie. You know, just real quickly, we are a national healthcare consulting firm. We have over 20 offices, including one in Denver. But of relevance to this conversation today, we have a team that really focuses on and specializes in the justice involved population. And I personally, for the last 5 years, have been working exclusively in that area. We've now supported almost 70 county jails across the country and several DOCs with their MAT implementation efforts. That work's been done under public funds. So our resources, our materials are public facing, and we have made several of those available to Kelly and Becky to share out with you guys as they feel would be useful. So hopefully you'll see those coming. Just a brief introduction for Laurie and me. So I, again, have been leading projects in several states and DOCs for the last 5 years, focusing on how we help county jails and DOCs build effective teams and sustainable programs to get MAT going and keep it going in jails and DOCs. And Lori, you want to introduce yourself as well?
Sure. Thank you all for your time today. I love to do work which feels like it's in my own backyard. So I live in Fort Collins, Colorado, and like Bren said, I'm working with HMA out of the Denver office. Before I came to HMA, I worked for the Larimer County Sheriff's Office in their jail division for 12 years, and then was the director of our alternative sentencing department for another 6 years before I moved into the behavioral health space and successfully passed the behavioral health initiative in 2018 that provides the dedicated sales tax to expanding and enhancing behavioral health across Larimer County. Led up the effort to create a $3 million grant program that we distribute dollars out to community providers for much work that we've been talking about today, the medication-assisted treatment and parallel therapy work and treatments for folks in trying to disentangle people from the criminal justice system that have behavioral health challenges. In Larimer County, we just opened up in December of this past year our 64-bed acute care facility and are seeing really strong results already about diverting folks from the criminal justice system in our hospital setting and trying to get them into the right levels of care at the right time. So I am really excited to be in front of you all and seeing how many folks in Colorado are already passionate and dedicated to the work of medication-assisted treatment in jails. And we look forward to any questions that you might have as we go through our presentation here.
Thanks, Laurie. Let's go to the next slide. So when we talked with Kelly, Danielle, and Becky the other day and offered to come and share some information with you all, I had suggested that it might be worthwhile to talk about the idea of the integrated multidisciplinary team that it really takes to stand up Matt in a jail and keep it going. So that is the focus today. And what we have seen in helping, again, about 70 county jails across the country do this is a completely unscientific, unvalidated number, but I think it's been borne out over time with experience that work is really maybe 10 to 15% technical change, like the conversation we just heard around medications, dosing, et cetera. Again, very critical, but it really only happens and works if we're really tending to that 85 to 90% of adaptive change, or really like the change management aspects of this work. And so that's what we're going to delve into a little bit today for you guys to reflect on where you are currently with the MAT system that you have, and how that is sitting in terms of your culture and your organizational environment, and if there's opportunities to maybe enhance or improve that. So, the previous slide said, what's the biggest reason for a system change to not happen? Well, simply put, it's you don't have the right buy-in. You don't have the adequate buy-in from the key people that really need to make that change happen. So, of course, with Matt, we are looking at a lot of stigma that occurs around people with substance use disorders, people with justice system involvement or serving time in jail or prison, and of course, even about the medication itself, right? So that idea that, oh, Matt is replacing a drug with another drug. So go ahead and go to the next slide, if you would, Lori. So again, thinking about making your jail system change, and in the context of your county partnerships that are necessary to support reentry, it's really about driving system change and making sure all those wheels are on the track to support all the hard work that you all are clearly doing in your jails to bring Matt to your county residents. The issue with that, though, knowing it's about change management, is really nobody likes change. It's just a human thing. Human beings do not like change, do not respond well to change. So all of you, I'm going to guess, by virtue of you being in this meeting today, are in some form or fashion champions for this effort at your jail. And so you are really the ones that are in that driver's seat on, go ahead and go to the next slide, Lori, please, on making sure that the different building blocks that are needed to make your MAP program work and to make it sustainable are in place. So again, breaking out change into the adaptive part, which is the people part, values, attitudes, opinions, beliefs, education, and the technical part, which includes all of those many details you guys have to attend to around this effort: budget, staffing, protocols, workflows, data, information. You all as champions, and you're up there in that top left box under organizational leadership, are the ones that are really charged with getting all of this in place to make sure your MAP program works. So let's break that down a little bit more. Let's go to the next slide. I titled this session today, The Integrated Team Model, and that's just really a foundational paradigm shift in this work, is the idea that, we have this one person in a jail with an opioid use disorder who's vulnerable to overdose and other adverse results if they don't get treatment they need and don't get into recovery. And we have people around that person who have a different role and a different perspective with that person in the jail. Each of them is legitimate and valid and equally important. So to medical and healthcare, that person is a patient. For behavioral health, they're a client. For, of course, correctional officers, for security and custody, that's a detainee or an inmate. And then, of course, we also have the courts and legal system, which intersects with this, which is the defendant. So going to the next slide, thinking about, that all those different key stakeholders who have a role and a responsibility with that person, and then with the jail sitting in this larger context of the treatment ecosystem and the justice ecosystem, That's a lot of complexity. It's a lot of moving parts. It's a lot of different partners. So thinking through, how do we approach this systemically? How do we drive the needed change and the system change is going to be really important to your continued success with all the great successes you guys have already had. Let's go ahead and go to the next slide. So just maybe taking a little bit of time to reflect when you think about who within the jail has to make MAT happen: nursing, prescriber, custody, people providing any support or therapeutic services, and of course, those key partners in the community to support reentry, especially. Who's currently at the table? Do you have on your team everybody you need to support this effort? Is there somebody else that maybe needs to be at that table and be part of that discussion, both inside the walls and outside the walls? And then really kind of reconsidering, do we really have buy-in from each of the champions or people representing those key parts of the team? Do we have resistance? How can we really engage where we do see resistance and help people move along with the change effort? And also overall, how is the team functioning as a team? Let's go to the next slide. So of course, role clarity is a really important part of this. If everybody who's on that team who's responsible for supporting the MAT effort isn't clear on their role and responsibility, the system's going to break down. So let's go ahead and go to the next slide. So really drilling this down inside the jail, inside the walls, and the idea of implementing MAT as an evidence-based treatment for people with opioid use disorder. I know you all, I'm sure, have already been engaged in the effort to overcome stigma by creating a foundational understanding that substance use disorder is a chronic health condition. It's a brain-based chronic disease and can and should be effectively treated like other chronic health conditions, right? That's the aspirational ideal that we're all trying to move towards in the SUD treatment space, inside the correctional system and outside of it. There's still a lot of stigma around that. But when we approach this and we are doing the hard work that you all are doing, obviously you believe in it, you're engaged in it, and we're going to come from that premise that SUD is a chronic health condition, then we want to treat it like a chronic care proposition, right? So that includes understanding and evaluating for the health risks. What do we need to do to evaluate and put in place the right pieces to support that person's recovery? So that pre-release planning that's going to support their effective reentry and recovery in the community. And then when we can put all those parts in place, everybody wins. It's a win-win-win proposition, right? Overdose deaths are prevented, crime is prevented. You know, the data shows us that when incarcerated people receive access to MAT, that overdose deaths are reduced as well as recidivism. So for the many sheriffs, jail chiefs, jail administrators we work with, you know, they feel a charge of security and responsibility for their communities. And they also don't want to see people coming back in their jail through a revolving door if that can be prevented by them getting access to this treatment. So everybody's got skin in the game. Everybody can benefit from having this treatment available. Go to the next slide, Lori. And it's also a hugely complicated proposition. So this slide, and may give you a little bit of a headache when you just see it. It's a little bit of a spaghetti diagram, right? So we use this a lot. I mean, you guys already know how complex it is because you're in the jail doing this work. So there's a lot of different partners, a lot of different players at the table, right, that are part of the team to make this happen. And I think this slide, you know, illustrates why, again, it's really important to have a very structured, standardized, integrated team approach to this effort. Let's go ahead and go to the next slide. Because by putting that structure in, we can really bring a focus and clarity and progress into what can sometimes feel like chaos. So I mentioned earlier that, you know, this work really only is successful if the right champions are on board and are part of the effort in the team. So of course, sheriff is the #1 champion. We actually require, when we work with county teams, a letter of support from the sheriff, because we understand it's the sheriff's house. Nothing can or should happen in the jail without the sheriff's support. So the sheriff is champion #1. And then of course the sheriff's designees to continue to represent the sheriff's perspective in the effort is important. Prescribers and nursing to support the actual medications for opioid use disorder, prescribing and administration. For behavioral health, who play a role in screening, assessment, and making sure those additional evidence-based treatments are provided. And then, of course, it's always important, we don't just focus inside the walls, we focus on what's going to happen when the person with whom you've done all of this hard work to either continue their treatment or initiate them on MOUD while they're incarcerated. When they walk out that door, how are we going to make sure that they don't fall off the cliff and that they get connected effectively to treatment in the community? So those are also key community partners, both providers and probation. So I'll also say, if you have thoughts or questions or, comments as we go through this, please drop them in the chat, and Laurie can respond or flag those. We'd love to hear your thoughts on what your own change management, your championing efforts, how those are going, what you're noticing in terms of successes and challenges. So breaking this down, again, how do we operationalize this idea that you have to have the right team at the table, the right champions, and that everybody is able to pull together to make this effort successful? So there has to be a common goal and shared mission. We actually encourage our jail MAT teams to draft a brief mission, vision, and goal statement for their MAT implementation efforts, so they can use that for communication all the way through 100% universally of the staff in the jail, so everybody's clear and understands what the effort is, what everybody's trying to do. Another piece of it has to be really identifying and responding to stigma and needs for education where that pops up. Of course, creating shared learning opportunities and continuous quality improvement. I'm going to talk more about that in a minute. It's really important to have an actionable implementation plan. Briefly put, like, what are we trying to do? Where are we trying to get to? And who's responsible, when, and what are they doing, and how are they going to do it? So having that actually documented and using that as an ongoing active document that is a tool for the team is super helpful. We talked about making sure that who, what, where, when, how, the defined roles and responsibilities is important. And then making the time and space to actually create a multidisciplinary team that is going to meet on a regular basis, to have that kind of institutionalized, could be part of another standing meeting or a new meeting where the maybe particular case staffings or having a forum to address and respond to problems as they come up, and again to collaboratively work together to overcome those barriers through that shared experience and input. And data is very critical. Let's go to the next slide. So this is another way of visualizing this. So if you want to think about how do you actually operationalize an integrated team for jail MAT in your jail. So regular time and capacity for both meetings and tasks for the multidisciplinary team, the jail MAT team is just what I'm going to call it for shorthand. So that has to be an intentional effort, right, to make space for that. What is the team trying to accomplish? And not just your overall North Star and your overall goals, but really those, breaking that down into those actionable tasks with assigned roles and responsibilities and timelines, and checking in with each other on how are we progressing. As they say, hope is not a plan. And soon is not a timeline. So we really want to make those efforts concrete. And in terms of responsibility, also always being thoughtful of, again, about who's on this team. Does this team have the empowerment and the capability to move this effort forward? Do we need somebody else on the ground to actually make it help happen? Or are we hitting resistance or blocks somewhere where we need to go back and reconsider additional leadership input that might be helpful here? And then really important part of technical system change is using data. So first of all, again, having specific goals, action plan to get you to those goals, and ideally a way to measure that. How do we know if we're getting there? How do we know if we're achieving our goals? I understand very well how challenging it is to collect data in jails around the MAT implementation effort. It's a core pillar of our work with our county teams, and we really try to help them, build strategies and capacity to do that. It's definitely a case where the juice is worth the squeeze, because when you have the data about how well your MAT implementation is working, it not only informs your jail MAT team, but you can also use it to support the sustainability for your program, right? When you can show the results and the progress you're making through data. We've seen many counties use that to be able to go forward and get sustainable line item funding for their MAP programs when they have the right data on board. Next slide. So again, thinking about your team, for those of you who have been parts of other teams, you already know a lot about the science of putting together a good team and making a team work. Again, this is an opportunity to just revisit that concept and reflect on that in terms of your jail MAT effort. So, everybody at the table has valid and important expertise and experience and input. I think one example of where this might come into play is around diversion. So diversion is always a concern in jails, not just around MOUD, but other medications and substances as well. But specific to MOUD, it's really important that there's both a clinical perspective and a custody and security perspective, right? And that those constituents, those stakeholders, have a way to interact with each other and provide important information and insight, and to develop a plan together on how to respond to diversion incidents around MOUD. So that would be one example of, where we have this structure in place, where we understand each other's different goals and agendas and perspectives. A medical prescriber from MOUD in a diversion incident has a different perspective than a jail chief or custody officer does, but it's all valid and important. And again, the idea is integration. So making a space where we can really hear from each other and learn from each other and move forward together with solutions is what that integrated team will enable you to do. Next slide. However, this is all good stuff. Everybody could see that it makes sense, I'm sure. But this is, again, what we all too often run up against with any change management effort. So here we have these cavemen, toiling along, dragging this cart full of heavy rocks with these square wheels, and they're sort of like digging down into the mud. And we have this other guy running behind him saying, hey, wait up, you guys, I've got this new thing, this round wheel. And they're saying, no, thanks, we're too busy. So, the point being that even when this stuff is good stuff, it can be really difficult to find the time and the space to make it happen. What I would say here is it's worth it. And for you all as champions and influencers in this effort to maybe double down and revisit how you make sure you're making space for this intentional kind of change management effort carried forward by an integrated jail MAT team. Next slide. These are some of the, and we're going to be wrapping up here and see if you guys have comments or questions. And I'll also ask, Laurie, Kelly, Becky, and everyone to pitch in as well. So these are kind of the key building blocks that you want to consider. In regards to your MAP processes, whether that's medication administration, screening and assessment, whatever those specific processes are. In terms of workflow, do we have a standardized process? Do we have a way of evaluating if our process works? Do we have a way of communicating out what the process is to make sure everybody knows what it is, and a way of assessing if it's actually working, being communicated effectively? Is there anything else we need to do around our organizational culture to make sure the buy-in is there and that we have the foundation we need to build in this standardization and quality improvement? And of course, the tools and the accountability. Accountability ties both to the people part, the roles and responsibilities, and people being accountable for their roles and responsibilities, but then also that technical part in terms of data. Again, having data is a great way to have a mutual means of holding each other accountable. Next slide.
Bren, before we move on, I wanted to just mention a comment that was made in the chat.
Yes,
I believe,
please.
Yvonne, was that yours? The biggest challenge is the provider through Turnkey. He seems to have a certain attitude towards the substance use disorder, running into issues with how he prescribes MAT meds, and policy and state legislator being so vague that it's hard because there's no specific guidelines to follow. I think that would be a great opportunity to just mention the office hours that we have created for prescribers and some of that work to help reduce some of this stigma and create more of that collaborative team. So I thought you might want to address that.
Yeah, well, you just did a beautiful job of doing that. I think, people with badges want to hear from people with badges, and physicians or prescribers want to hear from physicians and prescribers. So I think creating those opportunities or forums to influence folks based on others who maybe don't have as much stigma toward the medications or toward SUD is really, we have found really important. One of the ways we've operationalized that is with prescriber office hours. I will say this is not an unusual phenomenon. Prescribers are accountable to their medical license, and they have prescribing authority. And it is often a big change management effort to help move prescribers along to get with the program essentially for standard of care for treating opioid use disorder. There are standards of care, there are guidelines. It may not be legislatively dictated, nor should it be by the legislature, but medically and clinically, there are definitely prescribing guidelines and standards of care that can be referred to. Again, we have found that having a prescriber, work with a prescriber such as the one you're describing to help move them along in that kind of doc-to-doc way can be really, really helpful. There's still a big problem with lack of individualized treatment. So one of the things we see is sort of like standardized dosing. Everybody I'm speaking of a particular county I worked with in California where when we first started, their prescriber, everybody gets 8 milligrams of buprenorphine, right? So we see that a lot in jails, not appropriate, not standard of care. It's not only a problem because it's not standard of care, but we know from the very large body of case law around accessibility of MAT in correctional settings, failure to provide individualized dosing or individualized treatment has found prescribers, healthcare agencies, counties, and jails liable to plaintiffs in that. So there's, kind of the clinical case. There's also the risk management case based on a pretty big body of case law around the need to prescribe appropriately. I really appreciate you bringing that up. It's something that happens a lot. Laurie, is there other questions or comments in the chat? I think we're getting close to the end of the slides, but
yeah, there aren't any other ones right now, but I'll keep my eye out for them.
Thank you. Let's go ahead. Try and remember. Yeah. I was right.
That's
That was
us.
it. So, again, we're here because we have a vested interest in Colorado, of course, being home territory, but also speaking for myself, and I know Lori feels this way too. We have a tremendous passion for this work. And I am so grateful to all the great work that you all have already done. By virtue of being the cohort you're out there in the leading edge in the country. I mean, nationally, unfortunately, most jails do not have any form of MAT available to people coming into their jails. So kudos to you guys for being on the leading edge and all the great work that you're doing. Really, really, I know it's a lot. It's a lot of work. It takes a lot of effort. So very grateful for that. We are more than happy if you have follow-up questions that you would like to send us. You have our contact information there. We're happy to do that. And I'll just pause there and see if there's any questions or comments, or Kelly, if you want to pick it up to continue for the rest of the time that you guys have together.
That sounds great. Bren and Lori, thank you both so much for hopping on today. One thing that I just want to point out in front of all these folks here is there were some very hefty legislative requirements that were passed that affected jails specifically as it had to do with MAT. And so they were really, a lot of these people in programs in jails that didn't have MAT, excuse me, were really kind of thrown to the wolves, more or less. And I just want to say we have been very pleasantly surprised and grateful and impressed for how people have sort of taken these requirements of them and ran with them the best that they could. Obviously, there's always room for improvement, change, all those kinds of things. But I just kind of wanted to acknowledge, especially this audience and this group in Colorado really had some tough things thrown at them. And I know it was a struggle, or still is a struggle at times, especially for our smaller communities. So just wanted to highlight that in front of this group and just let you all know that we appreciate your efforts. We see your efforts, and we're grateful for agencies like HMA who can come in and give even more direction and guidance when it comes to how to set these programs up properly.
So the timing on my hand clapping was bad. Like I was going to hand clap all of you, and then it actually started hand clapping when you mentioned us. So I wasn't clapping for us. I was clapping for all of you guys. Yeah, because
that's genius. Give yourself props. I love it.
Yeah. Thank you all for the good work you're doing. You're the one saving lives and working out all of the kinks in the systems and bringing the necessary teams together to make this work happen. Please feel free to reach out to us if you've got questions. We've got CQI processes, we've got documents and forms, and we would love to be a support to anybody that is having pain points in implementing this process.
Yeah, we have what I've actually been calling the Alexandrian Library of MAT resources, because we've been building it for about 5 years now. And we love to share it and help others with their efforts. So let us know. Glad to help.
That's fantastic. Thank you both so much. Thank you to all of our speakers today. This has been a very informative meeting. I think before we go, Becky has one announcement she'd like to share regarding the training that we're going to provide on the game. So Becky, go ahead.
Thanks, Kelly. Appreciate that. And real quick, before I say that, Bren and Lori, could you please, I don't know if I saw it, and if I did, it got buried. Could you please put your contact information in the chat so everybody has that? Thank you so much. So I wanted to mention the GAIN training. So we mentioned at the beginning of this call that we were planning on June 19th for our training for providers for the GAIN. Kelly, if you're on here, thank you for pointing that out. June 19th is Juneteenth and is a holiday, is a state holiday. So we will not be around. So thank you, Polly. We kind of scrambled real quick on the sidelines here to try to figure out a different date. So we have moved that GAIN training to June 12th. So the learning community meeting for June, and therefore the GAIN training for providers for those folks actually doing the assessment will now be June 12th from 1 p.m. to 3 p.m. So please let your folks know that it'll be now June 12th, 1 p.m. to 3 p.m. I'm going to keep repeating it so everybody has it. We also scheduled a second date. I know July dates aren't great because that's the beginning of the fiscal year and folks are on vacation. But if some providers cannot attend June, we will have a training on July 10th, also from 1 p.m. to 3 p.m. And Camille Farron, who is our lead program manager, she will be doing that training. We will also be coming out with a third training date in August. That is kind of a to be determined right now. But if folks can either put on hold June, and now I lost it, June 12th or July 10th, both of which 1 p.m. to 3 p.m. Sorry about that. That's our fault that we didn't notice that's a holiday. So we will be more mindful in looking at that in the future. With that said, questions, concerns, anything anybody would like to discuss in the next 10 minutes that we've got on this call?
Cool.
All right, cool. Well, we are all set again. Bren, Lori, if everybody else, it looks like David's still on this call. So David, anybody else that might have presented today, thank you so much for your time. Everybody on the call from JBBS, thank you. Thank you for being here. Everybody, great information, and thank you for the questions and comments. We will see you all on our monthly meetings, and then we have our next meeting. It looks like we have a roundtable meeting for jail personnel on May 15th from 2 p.m. to 3 p.m. So thanks, everybody. Appreciate you. Take care. Bye-bye.
Thank you.